For this module's laboratory interpretation clinical Pearl, I'm going to go over the homeostatic model assessment for insulin resistance, also known as HOMA. And this is basically a calculation that's used to identify early patterns of insulin resistance. Now, when you look at the HOMA calculation, there are different ways to identify this HOMA number, which is a marker for the degree and severity of insulin resistance, depending on what kind of units you're using. So you can see milligrams per deciliter units, it's glucose times insulin divided by 405. And if you're looking at the mLs versus liter, it's glucose and insulin times 2.5. So you want to look at your lab test and see what units are available. Now, if you just type in HOMA calculator, you can find many online sources that you can use to quickly do the calculation for you, and then whatever units you're using with the lab test you're running to determine the range. So once you find a calculator you like online, it can be very easy just to plug those in and just get the information that way. Now, when you look at this calculation, there's a range of this HOMA insulin resistance normal range from 0.5 to 1.8. Now, there are different research studies showing abnormal HOMA scores for different ethnicities, and they're really looking at these really for like late diabetes. But as far as the ranges that we're concerned with, which is identifying insulin resistance at the very early stages, we want levels to be less than 1.8. Less than 1.0 is like optimal insulin resistance sensitivity. That's what you would like to shoot for someone, really having really efficient blood sugar signaling systems between how the glucose load leads to insulin surges, and things like cutting down on sugar, physical activity, having more muscle mass, are all things that improve this insulin resistance pattern, or this HOMA score. So if they're above 1.9, that indicates early insulin receptor resistance. And if they're above 2.9, that indicates significant insulin receptor resistance. Now, when you look at routine lab work, most routine labs are going to have a chemistry panel. The chemistry panel is going to have glucose in there, like a fasting glucose. Adding insulin is usually an additional test. Having markers like HbA1c is an additional marker. But if you want to identify early insulin resistance, being different than looking at glycation of glucose like HbA1c, you probably want to add a routine insulin, fasting insulin, into your panels just so you can do this calculation. So let me show you some examples of this calculation and that can be used in your practice. Now here you can see a person's test results. And if you look at their glucose levels, if you just looked at fasting glucose, the fasting glucose is 84. So that would look like it's normal. Like there's no indication that their glucose levels are high, like you would see with insulin resistance. You would get some clues that the glucose levels were high when triglycerides are high. Usually when you see high triglycerides, you should always be thinking insulin resistance, because when glucose can't get into the cell, glucose gets converted to triglycerides. Now in this scenario, if you look at the HbA1c, let's just say you only had the glucose and HbA1c, everything would look okay. The HbA1c is 5.6. So that would make you a little bit concerned. It's right on the borderline of prediabetes, which is at 5.7. So you got to remember, these fasting glucose levels are not, this is the least reliable individual marker for insulin resistance. It's just the fasting glucose. You want to look at other markers. HbA1c is giving some clues, triglycerides are giving some clues. Now in this scenario, fasting insulin was done, and look at the fasting insulin, it's 53.4. So this is clearly insulin resistance here, okay? Now in a scenario like this, when the insulin is this high, you know they have insulin resistance unrelated to their fasting glucose level. And then in this scenario, if you do the calculation where you put in 54 and 84 into these calculators that can then calculate the HOMA score based on these ratios here, the score would be 11. So remember, anything that's above 2.9 indicates significant insulin receptor sensitivity. So, here we go. So this is 11. So 11 is above this reference range, above 2.9, which is significant insulin resistance. Now, this is not the best example of where HOMA testing shines. Let me give you another example. This is a blood test of a patient. Now, here you can see a person that was given a 2-hour glucose and insulin test. So they went into the lab, they had a fasting glucose and a fasting insulin conducted. And then an hour later, they measured their glucose and insulin again. And then 2 hours later, they measured their glucose and insulin again after they gave him a glucose load. Now, if you were to just look at this person's lab results and you didn't do this, glucose challenge test, which patients hate, and sometimes it's the only way to find early insulin resistance, with the exception of sometimes you can use the HOMA calculation and not have to put a patient through this difficult test for patients. I don't know if you've ever done a 2-hour glucose tolerance test, but you should probably do one before you're ever recommended to a patient. They basically drink, a really syrupy, super saturated sugar Gatorade-like drink before the test, and then it really spikes your blood sugar levels up. For some people, they really crash afterwards, and some people just will feel off the rest of the day, especially if their blood sugar system isn't efficient. Now, if we were just to have this person's fasting glucose levels, C would be 93, and if all we had was their fasting insulin levels, you can see that it's 141. The previous levels when this was done was 232, but it's 141. They would look like they're within the normal range of a fasting glucose and fasting insulin. However, if you were to go through and put those numbers into this calculation, you could see that their HOMA score would be 14.2. I'm sorry, the fasting insulin is 18.1. So if you see the fasting insulin is 18.1 and their glucose at 93, you can see their HOMA score would be 4.2. So this would identify early insulin resistance without having to have a person get into the first hour and second hour of a glucose tolerance challenge to identify their insulin resistance patterns. So that's one of the main advantages of HOMA. It's for cases like this where they have subtle insulin resistance, they have like all the symptoms of blood sugar levels crashing, like they eat a meal, they have like fatigue and mood changes and want to take a nap and crave sugar after they eat. But when you look at their normal lab work, their actual fasting levels and maybe even their fasting insulin levels look normal. And you wouldn't really find their imbalance unless you did a provoked glucose challenge. Now, the provoked glucose challenge is difficult, so another way to quickly identify if they have insulin resistance patterns is to do this HOMA calculation. And here you can see when we look at their fasting glucose and their fasting insulin, even though they were in the normal reference range, when you plug it into the HOMA calculation to really look at the response of glucose load versus how insulin responds against it in a fasting state, you can see that this person is definitely 4.2. They're above 2.9, which indicates significant insulin resistance. And this would be your baseline score that you would look at these interventions before. Now, if you took the Cardiology Institute Diabetes and Blood Sugar course, we talked about different scales of insulin resistance. And the earliest pattern would be for someone who's got blood sugar symptoms, but the lab test is normal. And that's when you would use the postprandial elevation, where you would do a challenge like this. One of the things you can do, which is still not as good as the challenge, but much easier on the patient, is to do that HOMA calculation. So your HOMA calculation is going to be able to find some of the earliest types of hyperglycemia responses, like in these very yellow stages. So remember, like when you look at the downward spiral of hyperglycemia, there's normal glycemic responses. Then there's this postprandial dysglycemia, which you won't see with fasting test. You'll have to do a challenge test, but you may see some of those, not all of them, but some of those with the HOMA calculation. And then at some point they get insulin resistance and metabolic syndrome, and it's pretty clear to see their downward spiral. So when you look at, again here, when you look at the glucose patterns, postprandial dysglycemia, postprandial insulin and glucose are high. Another thing you can use to catch this stage before you see elevation of glucose above 100 and triglycerides high is that elevation of that HOMA index. So the clinical profile this month is to consider evaluating these. Go online, just type in Google HOMA calculator. You'll find one that you like. There's many of them available, and start start adding insulin if you don't have it in your routine panel, fasting insulin, and when you have your fasting glucose and insulin, you can calculate these. Now, these levels that you're measuring with fasting glucose and insulin is just your overnight glucose levels or your overnight insulin levels. Remember, HbA1c is measuring glycation for 4 to 8 weeks, fructosamine for somewhere around 2 to 3 weeks, and then the glycomorph is looking at hyperglycemic spikes. So those are different forms of testing. But the HOMA is really a subtle way to look for things you may find with the glucose-insulin response time that isn't as difficult for your patient. So the bottom line is, with this HOMA insulin receptor calculation, depending on the units, you would use these different mathematical calculations. You can do these online. And then you want to make sure your patient is less than 1.8, and ideally, optimally, less than 1. And then as soon as they go above 1.9 in their HOMA score, they have some early insulin resistance. And that may have not been caught unless you've done a postprandial challenge test. And once it's above 2.9, you'll typically see other blood sugar changes over time. But it's a nice tool that you can use in your practice. So those are the main things I wanted to cover for this clinical pearl, just the homeostatic model assessment for insulin resistance. And I hope you get a chance to incorporate that into your practice. I think you'll find it useful, especially for those subtle insulin resistance patterns in the very early stages. Thank you.